Hello everybody. Today we are going to discuss about nutrition in pancreatitis. Acute pancreatitis is the acute inflammatory process of pancreas with variable involvement of the other regional tissue and the remote organ system. So the diagnosis is based on the two of the following three criteria. Abdominal pain consistent with the pancreatitis, serum amylase lipase greater than 3 times upper normal limit, characteristic finding of the abnormal abdominal imaging. The two major common etiologies of the acute pancreatitis are gallstone and the alcohol. Other causes include medication, infectious disease, metabolic causes such as hypercalcemia and there are two distinctive phases of acute pancreatitis. That is, early phase within first week, characterized by both local pancreatic inflammation, the systemic inflammatory response syndrome, and/or organ failure. Late phase is characterized by the local complication and persistent organ failure. Hence, prevention and the management of systemic inflammatory response syndrome, organ failure, and complications are imperative in order to decrease morbidity and mortality in this potentially fatal disorder. Nowadays, there are no specific medication found to effectively treat acute pancreatitis. Therefore, management is focused on supportive interventions such as fluid resuscitation and nutritional intervention. Nutritional management has demonstrated necessity not only in the prevention and treatment of malnutrition, but also in obviating systemic inflammation, reduction of complication, and therefore modifying the course of disease. Now, about pathophysiology of malnutrition and nutrient metabolism in acute pancreatitis. Multiple factors are able to deteriorate nutrition status in acute pancreatitis, and one of the most important factor is inflammation. Inflammatory cytokines like tumor necrosis factor alpha, interleukin 1 and 6, stress hormone like cortisol, catecholamine, glucagon released during pancreatitis, results into the abnormal metabolism which is similar to sepsis. Resting energy expenditure in patient with pancreatitis is generally higher than healthy individuals because of inflammation-induced hypermetabolism and or septic complication. So this in resting energy expenditure measured by the indirect calorimetry, which is increased in the 61% of patients with acute pancreatitis, in 82% in pancreatitis complicated by infection. Nutrition support may help restore energy balance and prevent malnutrition in these circumstances. Severe inflammation leads to protein catabolism. Amino acid release from the protein breakdown provide substrates for production of acute phase protein. This was found in 80% of patients with severe necrotizing pancreatitis. Nitrogen balance can be negative in up to 20 to 40 gram per day, and patients with negative balance had tenfold higher death rate than those with normal balance. Muscle mass and function standard measured by grip strength, respiratory muscle strength, rapidly decline within 5 days without nutrition support in healthy men suffering from acute pancreatitis. Regarding carbohydrate metabolism, hyperglycemia is often found in patients with pancreatitis. It is the result of insulin resistance, increased glucose production from the liver, and impaired insulin secretion caused by beta cell damage. So, hyperglycemia is related with pancreatic necrosis and infectious complications. As a result, blood glucose should be monitored and controlled in all patients. Hypertriglyceridemia is common and can be either a cause or consequences of pancreatitis. Lipid catabolism and impaired lipid clearance resulting from decreased insulin secretion contribute to elevated serum triglyceride. In the absence of gallstone and significant alcohol consumption, severe hypertriglyceridemia can be considered as a cause of acute pancreatitis. Serum triglyceride level should be monitored, especially in those who receive intravenous lipid emulsion. Malnutrition in acute pancreatitis can arise from decreased oral intake as a result of anorexia, abdominal pain, vomiting, ileus, gastroparesis, gastric outlet obstruction, inappropriate fasting for pancreatic rest, In addition, pancreatic exocrine dysfunction leads to maldigestion of nutrient and may persist up to 6 to 18 months after acute attack. Micronutrient abnormality are common in acute pancreatitis. Chronic alcohol consumption frequently lead to micronutrient deficiencies, leading to inadequate intake, decreased absorption, and impaired storage and utilization of nutrients. In patients with alcoholism, biochemical data demonstrate several micronutrient deficiencies, including vitamin B1, B2, B3, B12, C, A, folic acid, and zinc. Moreover, the risk of deficiencies increases in patients with severe complicated pancreatitis requiring prolonged admission. The etiology is multifactorial, including decreased intake, maldigestion, increased demand from severe absorption, and hypocalcemia can occur in 40 to 60% of patients. The underlying cause of hypocalcemia may be related to saponification of calcium, hypomagnesemia, decreased parathyroid hormone release, and increased calcitonin level. Now, fall of pancreatic rest concept. Nutrient delivered to the gastrointestinal tract proximal to the mid-jejunal stimulate pancreatic enzyme secretion. Traditional thinking was that this may lead to increased pancreatic autodigestion and worsening pancreatitis. So, as a result, the concept of pancreatic rest has formerly used to guide management of acute pancreatitis in Europe and America. This concept states that enteral nutrition should only be started when abdominal pain has completely resolved and pancreatic enzyme has normalized. Based on this concept, the strategies used to minimize pancreatic stimulation, such as parenteral nutrition, enteral formula, and stepwise introduction of oral diet, beginning with the clear fluid. However, this concept is based on only physiological assumption and is not supported by the good scientific evidence, and indeed may result in the worsening of nutritional status and poor outcome. Further studies have found that pancreatic enzyme secretion is significantly reduced in acute pancreatitis, and secretion was inversely related to severity of pancreatitis. A lower secretion of trypsin, amylase, and lipase was found in severe pancreatitis. In addition, enteral nutrition use resulted in clinically significant exacerbation of symptoms in only 4% of cases. These data suggest that injured acinar cell cannot fully respond to physiological stimuli and may explain why enteral feeding is safe and does not worsen autodigestion during the attack of pancreatitis. Since 1990, several randomized controlled trial and meta-analysis have demonstrated safety and benefit of enteral nutrient in terms of mortality, multi-organ failure, infection, complication, and surgical intervention. This evidence support the administration of enteral nutrition to stimulate and maintain gut function, which is opposite to pancreatic rest that may give rise to gut dysfunction and worse clinical outcome. So enteral nutrient help maintain gut integrity, gut associated lymphoid tissue, and gut microbiota composition. This strategy reduces bacterial endotoxin and pancreatic enzyme translocation, which may attenuate systemic inflammation, multi-organ failure, infection, and disease severity in acute pancreatitis. So, based on this evidence, the gastrointestinal tract should be considered as an important organ in pancreatitis patients. So, patient evaluation. The principal aim of the patient evaluation is to plan nutritional support according to the severity of pancreatitis, to evaluate nutritional status, to identify the risk group that requires special nutrition need. Since acute pancreatitis has the vast spectrum of disease severity, the approach to the nutritional management is different between the mild, self-limited disease and severe fulminant pancreatitis. Thus, it is useful to evaluate disease severity before deciding on plan for nutritional treatment. Pre-existing malnutrition was found in 30% of cases at the time of initial attack. The risk group of malnutrition include chronic alcoholism and elderly. Malnutrition is associated with negative outcome and therefore nutritional status should be evaluated by validated nutritional screening and assessment tool, especially in high-risk population. Patients with chronic alcoholism require special attention to evaluate clinical signs and biochemical level of micronutrient such as vitamin B1, B2, B3, B12, C, A, folic acid, and zinc. Obese patient may be considered and managed as at a risk of severe pancreatitis. The pathophysiology may be associated with unregulated lipolysis of visceral fat around the pancreas, which inhibit mitochondrial complex 1 and 5, leading to pancreatic necrosis and poor outcomes. So this is the modified Marshall scoring system for organ dysfunction. The other scores which we can use is revised Atlanta score, Ranson score, then bedside is BISAP score. So we'll see what is modified Marshall scoring system for organ dysfunction. So the first is respiratory. That is, we have to calculate PF ratio. If it is more than 400, then 0 score. If it is between 300 to 400, 1 score. 2 score has been given if it is between 200 to 300. 3 score has been given if it is between 100 to 200. 4 points has been given if it is less than 100. Then about renal parameter, serum creatinine. 0 score if creatinine is less than 1.4. 1 score if it is between 1.4 to 1.8. 2 score if it is between 1.9 to 3.6. 3 score is between 3.6 to 4.9. 4 score is between more than 4.9. Then about cardiovascular system, 0 if systolic blood pressure is more than 90, 1 score if less than 90 but fluid responsive, 2 score if less than 90 not fluid responsive, 3 score less than 90 pH less than 7.3, 4 score less than 90 pH less than 7.2. A score of 2 or more in any system defines the presence of organ failure. So about nutritional management in mild acute pancreatitis. Mild acute pancreatitis is reported in 75% to 85% of all acute pancreatitis episodes. It is transient, self-limiting, therefore specialized nutritional care is not generally required. Patient can consume oral diet when abdominal pain, nausea, vomiting are full caloric solid diet can be started safely and stepwise. Introduction of oral diet beginning with the clear liquid is unnecessary. As for dietary composition, even though low-fat diet has been used in previous study, this does not support by good scientific evidence and may lead to inadequate energy intake. Tube feeding is only recommended when oral nutrition is not feasible for more than 5 days. An example of this patient with the poor oral intake resulting from persistent nausea, vomiting, and abdominal pain. Now, nutritional management in moderately severe and severe acute pancreatitis. Energy requirement should be estimated with indirect calorimetry if possible, or 25 kilocal per kg per day may be used as energy goal. Many non-static variables affect the energy expenditure in severe pancreatitis, such as body temperature, volume status, and medication. These variables results in poor accuracy of predictive equations. Indirect calorimetry is the gold standard to determine energy expenditure, and thus indirect calorimetry measurement may help prevent over and underfeeding. Energy requirement, whether by calorimetry or predictive equation, should be re-evaluated more than once per week in order to reach appropriate energy balance. The estimated protein requirement are higher than the healthy individual, that is 1.2 to 1.5 gram per kg per day. They may improve nitrogen balance and related to the decrease in 28-day mortality in critically ill patients. Mixed source of energy from carbohydrate, fat, protein should be provided. Daily dose of multivitamin trace element is recommended, especially in patients receiving total parenteral nutrition. Micronutrients should be supplemented in patients with confined or suspected deficiency. Now about role of nutrition support. Now about enteral nutrition. Enteral feeding should be considered as a preferred route of nutrition support. Local complications like necrosis, fistula, ascites, pseudocyst are not contraindication for enteral feeding. Enteral nutrition should be started after adequate resuscitation and stable hemodynamic status. Many studies have shown advantage of early enteral feeding in severe pancreatitis. Meta-analysis illustrated that early enteral nutrition within 48 hours after admission was associated with significant reduction in mortality, infectious complication, multi-organ failure, surgical intervention, and length of hospitalization. So gastric versus small bowel feeding. Initiating enteral nutrition in stomach is technically easier, cheaper, and may reduces the time to start enteral nutrition, while small bowel feeding generally requires special technique and take much more time for tube placement. For this reason, nasogastric tube may be used as first line therapy in order to achieve benefit of early enteral nutrition in patients with severe pancreatitis. Jejunal feeding should be considered in patients who cannot tolerate gastric feeding. It may be necessary in those with severe gastroparesis and partial gastric outlet obstruction, either from pancreatic edema or pseudocyst. An intraoperative jejunostomy tube may be placed for post-operative feeding in patients undergoing surgery from other indications. Now about pilometric and versus elemental and semi-elemental formula. Elemental and semi-elemental formulas are thought to induce less pancreatic stimulation, require less digestion, and are readily absorbed in the small intestine. Physiological study in healthy subjects found that pancreatic enzyme secretion reduced by 50% when polymeric formula was changed to elemental formula. Thus, semi-elemental and elemental formulas have been used in many studies on acute pancreatitis. Even though few studies directly compare between elemental and semi-elemental formula and polymeric formula, there are one RCT and other retrospective cohort study showing elemental and semi-elemental formula were not superior over polymeric formula in terms of feeding tolerance, diarrhea, and infectious complications. Furthermore, the weekly cost of semi-elemental formula is sevenfold higher than the polymeric formula. The use of polymeric formula may be effective and practical in severe pancreatitis. Now about parenteral nutrition. Parenteral nutrition is indicated when patient cannot tolerate enteral nutrition. Some patients develop intestinal failure, type 1 and type 2 from systemic and local complications such as severe ileus, duodenal obstruction from pancreatic edema and pseudocyst. When parenteral nutrition is required, mixed fuel solution is recommended, that is carbohydrate, protein, and lipid. Glucose should not be more than the maximum level of the glucose oxidation, that is 4 to 7 mg per kg per minute or 5 to 6 gram per kg per day. Target blood glucose should be in the range of 7.7 to 10 mol per liter is recommended. Intravenous lipid formulation can be safely started and the recommended dose is 0.8 to 1.5 gram per kg per day. The intravenous lipid emulsion dose may need to be reduced or discontinued if serum triglyceride concentration is greater than 4.5 mol per liter. Parenteral nutrition may needed to be delayed until after 5 to 7 days of admission. Because initiating parenteral nutrition at this point may be associated with better outcome including decreased mortality, overall complication, and length of hospitalization. Now about role of nutritional supplement. Glutamine is considered conditionally essential amino acid with antioxidant effect that improves immune function and intestinal integrity. Its depletion has been demonstrated in critically ill patients because of the increased demand during metabolic stress. Glutamine supplementation may play a role in critical illness, including severe pancreatitis. Studies demonstrated that glutamine was associated with lower infectious complication and mortality. In this study, only patients receiving total parental nutrition but not enteral nutrition showed a statistically significant benefit. Enteral glutamine showed improved in organ failure score without significant benefit in infected necrosis and mortality. Overall, intravenous glutamine seemed to give benefit in patients with total parenteral nutrition, while beneficial effect of enteral glutamine needs to be investigated in the future. The recommended dose of glutamine supplementation is between 0.3 to 0.5 gram per kg per day. Now about probiotic. Intestinal barrier dysfunction may induce bacterial translocation and infected necrosis, being major cause of morbidity and mortality in severe pancreatitis. Probiotic may help improve gut integrity and immune function and thus prevent bacterial translocation. Lactobacillus plantarum decreases intestinal permeability, infectious complication, systemic inflammation, multi-organ failure, but did not improve mortality rate in small RCTs. In contrast, multi-species probiotic preparation did not reduce infection and was associated with increased mortality. These data suggest that the potential benefit of single-strain probiotic in severe pancreatitis, however, further validated studies are needed before its advantages could be confirmed. Now about omega-3 fatty acid. Omega-3 fatty acid have shown beneficial in anti-inflammatory effect and may improve systemic inflammation, multi-organ failure, and clinical outcome in severe pancreatitis. Meta-analysis of 8 small RCT demonstrated that administration of omega-3 fatty acid was beneficial for reducing mortality, infectious complication, and length of hospital stay, especially when received parentally. Nonetheless, large and rigorously designed RCTs are required to elucidate the efficacy of omega-3 fatty acid supplement in severe pancreatitis. Now about antioxidants. Antioxidants like vitamin A, C, E, selenium, and N-acetylcysteine may reduce inflammation, improve outcome in severe pancreatitis. Nevertheless, few small studies with varied dose and duration of antioxidant leaded to mixed. Later and well-designed clinical trials are needed to confirm potential benefit of antioxidant in this disorder. So this is the schematic representation of management of nutrition in acute pancreatitis. Severity assessment of acute pancreatitis. Mild acute pancreatitis can be managed with the solid oral diet. Moderately severe acute pancreatitis on-demand oral diet does not tolerate in 72 hours, then enteral nutrition via nasogastric tube within 48 hours. So, in case of severe acute pancreatitis, we need to start with enteral nutrition via nasogastric tube within 48 hours. If it tolerates, then we can if patient's condition is improving, then we can switch to oral diet. If does not improve it, then enteral nutrition via NJ tube. If then continue enteral nutrition via NJ tube, and if that does not tolerate, switch to parenteral nutrition. Now, summary of nutrition management in severe acute pancreatitis. Recommendation is energy requirement should be measured by calorimetry or 25 kilocal per kg per day. Protein requirement should be between 1.42 to 1.5 gram per kg per day. Early enteral nutrition within first 48 to 48 hours is recommended. Gastric or jejunal feeding is accepted. Intravenous glutamine can be considered in patients with the TP. Then pancreatic exocrine insufficiency should be monitored, especially in alcohol, severe and necrotizing pancreatitis.